The purpose of this afternoon is just to get everybody oriented to what this is all about and to kick off this really exciting project. The purpose of the next half an hour or so is going to be for me to give you a little bit of background information, answer any questions you have, and then Arya Sharma, who's the co-principal investigator with myself and Sherry Fielding, will be presenting a little bit of some of the materials, and then we'll have a break and a breakout session where we'll do a couple of concrete activities of things we have to do today. So everybody should have a name tag, and I think when you met Jody, and unfortunately Jody couldn't be here today, she's sick as a dog. But when you guys met Jody, she talked a little bit about some of the evaluation that we're doing for this. So we're using a mixed methods evaluation, and we're going to be doing qualitative, where we have to take notes in terms of ideas that come up and people's perspectives and thoughts on things. And that's why everybody has a name tag, because we don't know who you guys all are yet. As we go forward, probably we'll get to know everybody's name, but for the next while, that's partially what this is for. And so we can get to know you. So initially, I want to acknowledge our funder. So Alberta Innovates Health Solutions funded this project, and this was a project that was co-conceived with the PCN. So Sherry is one of the co-principal investigators with Ari and myself, and Robin has been very, very involved as the clinical champion on the project. So we want to acknowledge the funder. This is a 3-year funded project to do some in-depth evaluation of what we're doing around weight management. And then also want to acknowledge you guys and the Edmonton Southside PCN for being so instrumental in making this get off the. So this is just the little overview for what I want to achieve in the next probably 20 minutes of me talking and 10 minutes of questions. So we want to be really part of the PCN, and so is you guys getting to know us and us getting to know you. So I'm Denise. Arya is back there in the corner. Arya is a professor in medicine and does a lot of work with WeightWise and bariatric medicine. Maybe you might have even seen his blogs or shows and things. Dio, over there. Dio is our project manager extraordinaire. We sent our first report to funders today, and we're on time, on budget, thanks to her. So she's a miracle worker, so she will send you lots of emails and things, and she keeps things on track. Jody, who I think you guys all met, she came into the last staff meeting. She's our anthropologist on the team, so she specializes in cultural and anthropology, and in very many ways in healthcare, we are our own culture. And culture and this kind of approach to evaluation lends itself really well to understanding what happens in our world. Jody is our expert for that. So she's a postdoctoral fellow on the research team, and she's also what we call a practice facilitator. So if you look at the literature around primary care transformation, there's been some real success around the concept of having a practice facilitator role. And it's basically everybody's really busy. So when you're in clinical care, you're running. And oftentimes there's not a lot of time or space or energy or resources to do changes. And so a lot of times we'll come up with things in our work environment where we say, gosh, that just doesn't make sense. And you feel like you're constantly doing workarounds around things all the time. But the energy that it would take to change that is tough because everybody's fully committed in the clinical role. And so having this concept of practice facilitator, it's extra pairs of feet, extra pairs of energy to focus on a question, to take the feedback from the clinical world to say, this is constantly a workaround, we need to rethink that, and then to bring resources to bear to make that happen. So Jody is one of the practice facilitators, and Io comes to us from Essex, University of Essex. He just moved here with his wife about a month ago, and he's our postdoctoral fellow on the team with a background in epidemiology. So he's more of the quantitative side. He's in charge of the patient part of the project. And Io is our other extra pair of feet in terms of practice facilitation. And then we have Dr. Andrew Cave. And Andrew is a professor in family medicine and has a lot of background in terms of also qualitative methods and evaluation. Without Andrew, I'd be sweating more buckets about the fact that Jody's not here today. So I'm feeling good about the fact that Andrew's here. Jeff Johnson's not here today. Does anybody know Jeff? He's in public health. He's a professor of public health, and he does a lot of primary care research projects in terms of in PCNs. And Jeff is also the clinical director of the Strategic Clinical Network for Diabetes and Nutrition. So Jeff is really interested on what PCNs are doing around evaluation, and he has a lot of expertise and experience to help with making sure that what we're doing is really rigorous and shows off ultimately all the great work that the PCN does. Donna Menka, and Donna is the Director of Research in the Department of Family Medicine. And she also has a strong background in qualitative research. So she's lent her expertise to a lot of the background work on the project. Brent Hammer, you're going to see around. He's not here today. He's our research helper. And so he's going to be really involved with helping us with the patient part. So there's a lot of, we need to recruit 500 patients for this project. So he's going to be here quite a bit to help us with doing measurements and help us with doing consents and stuff on patients. And then Christian, I just want to mention that he's not here today. He's currently doing residency in internal medicine, but he was the postdoctoral fellow who was very instrumental on the writing of the grant last year. So we can't leave him off. So that's all of us, and we will get to know all of you guys as we proceed. This is a randomized trial, so I didn't know up to today who was going to be here, so it's all really exciting. And we'll figure out as we go groups what clinics everybody is from and what everybody is representing in terms of different disciplines. So the rationale, as you guys all know, obesity is important. It's expensive, it leads to a lot of chronic diseases, and it's hard to manage in clinic. And there's some suggestion out there in the literature that primary care-based models could be effective. There's just not a lot of really well done studies in primary care demonstrating what works. And where I got really excited and kind of came up with the idea for this project with Aria was in seeing some of my patients coming back from the PCN. So I had some of my patients coming back from some of the programming with transformative change. And if you look at what's out there in the literature, they shouldn't have been having the successes that they've had. So obviously there's things happening that are working really, really well. And we want to understand that better so that we can figure out how to disseminate that. And that was sort of the impetus for where this all got hatched from. Aria and Robin and many others, and I'm not sure, maybe some of you as well, were involved in the development of the 5 A's for obesity management. Has anybody in the room been involved with that? No? So Robin was, I think, yeah. And so that's a toolkit that's included in your binders. It's in this package here. But tools in and of themselves aren't enough. So we even know in places where the toolkit has been introduced and things like that, if we have barriers in the practice and things that are stumbling blocks to making things happen, you can have all the toolkits in the world, but there may be other systemic factors in place that prevent effective implementation. And so part of what we want to achieve is to work together with all of you to figure out what the next step is. So what is the secret sauce? How do you take all of this content and how do you make that really accessible for people working out there in the community? And we want this to be something useful for people who may not have the benefit of working in a PCN. You know, many of the PCNs in Alberta aren't as big or as well developed as this one. A lot of them don't have the same kind of programming as this one has or the same amount of expertise. And if you go outside of Alberta, there's lots of people that don't have anything like a PCN whatsoever. So are there things that we can learn from this group that will help us to create an implementation toolkit that people could use in other settings and other places to try to mimic some effective strategies for weight management? And then we want to prove that that's actually working and that we're getting the results that we think, so we can show that and show that in a rigorous way. Okay, so that's kind of what that's all about. So we want to co-develop from you. We are not coming with a bunch of academic ideas and saying, oh, this might be a great intervention. No, we don't want to do that. We've been working a lot with Robin and with Sherry to get some ideas to get the ball rolling. But what we want to do is work together with all of the professionals in what we call a learning collaborative so that we can take all of that rich expertise that's out there, cross-share it with everybody learns, and then we are going to be taking copious amounts of notes about that and really talking with you one-on-one and trying to do focus groups, trying to really explore what works, how people adapt things, what are the things about the implementation process which are really important to make this work for patients. And that's what we really want to try to understand and get at. We're going to use this toolkit as a kickoff point, as a place to start, but we also want your input on the toolkit. So when you take this thing that's been developed that people spend a lot of time on, which parts of this resonate with you as being useful? Which parts will you whip off the shelf if you have a patient to refer to? And which parts do you find cumbersome or not really applicable or not really hitting the mark? Or is there a better way to reconceive of those tools in order to make them more tangible for people to be able to effectively work with them? Okay. And as a practitioner, we want to understand from you what your clinical experience is with this area. What are the things that you think are that are important? We want to really understand that piece. And that's the piece where we're going to be taking a lot of notes about just people's comments, things people say, things people find frustrating. And what we want to do with the learning collaboratives is really have that develop so that the groups are really driving that. So we have a bunch of ideas that we've gotten with Sherry and with Robin, which I'll talk about in a little bit. But those are not exclusive. Those are just a kickoff idea generating list. So this is a little bit about how this works. In primary care, one of the challenges in the literature has been people will do things like a seminar like this afternoon, and that's it. And then they will look and see whether or not there's changes. That doesn't really meet it, does it? Because you don't really understand anything about the context. You don't really understand the reality that people might be facing in their clinic or in their situation, which may make interventions tougher, right? So what we've really moved to in primary care research is to say that interventions have to be iterative and you have to describe them. And so people like Miller and Crabtree will say principles scale, but interventions don't. So that is to say, you couldn't take an intervention that works brilliantly in the Southside PCN and just pick it up lock, stock, and barrel and take it to Crow's Nest and drop it in there, because their context is going to be different. But there might be principles that we learn which are really, really important. And so while the intervention might be slightly different, we may be able to stay true to certain principles and have that increase the effectiveness of a program in another setting. So this graph around is to say that these things are iterative, and what we want to do is make sure that we're describing it as the project goes so that we understand actually what really happened, what was happening in the context, what was happening in the intervention. That's why we're describing it. And at the end, we're going to be able to say these were the things which were really predictive of being able to have meaningful interventions. Practice and patient level interventions. So we all see patients, and we all know that there's certain things that we learn in terms of that practical knowledge of the doing, which we want to extract. And then there's also context things. We're all in different clinics. Those clinics are made up of different groups of people, different personalities, different physical plans, different structures, different lengths of time being affiliated with the multidisciplinary team, right? We have new clinics in the PCN that don't even have nurses. We have like 15 of them. And the patients that are coming for this project are coming from all these different clinics, right? And so we want to have a sense of what's happening in the different environments so that we can describe it really well. Over here, this is all the stuff around change management support, SMART goal setting, which we do with patients, but it's also SMART goal setting that we do with our clinics. What is it, the things that make you pull your hair out about your clinic when it comes to weight management? Is the scale sitting out in the middle of the hallway? Is there a lot of resistance when you want to get things measured on patients? Is it really challenging to get reminder phone calls generated before you see patients? Like, what are the things that are in the day-to-day work which are cumbersome? And those are places where we, through the practice facilitation, through Robin and Sherry, may be able to or may not be able to help, but we can certainly help to try to, as a team, problem solve that. One of the goals of having a learning collaborative group is that you're going to get to know a group of your fellow colleagues very, very well. And the hope is that that becomes a vehicle for team change, so that you can not feel isolated, not feel like you're in a place and nobody understands your context, that you have a group of people that you're working together to tackle challenge and to move forward. And hopefully as we move to PCN 2.0, PCN 2.0 has higher levels of accountability with regards to evaluation, and it's going to have higher levels of accountability with regards to like the measurement and also the delivery. And we see that this may be a vehicle to help some of the docs change. This may be this kind of an approach may be a vehicle to help some of the practices move forward and change. And that'll be synergistic with the new practice facilitator, quality coordinator roles that you have with Dolores and with Robin. So that's kind of where we're coming from in terms of the way and why this is set up the way it is. There are other examples where this kind of thing has been really, really effective. So that's why we built it that way. This is the project. It goes over 24 months. Now this part with you guys is 6 months. But one of the big criticisms in this kind of literature is that, okay, yeah, so you did something, and what then? Are things changed? Is change sustained? So while we're actively only here with you guys for 6 months, we're going to still keep paying attention, and there will be some opportunities for doing some interviews and things like that down the road to see how some of the things that emerge end up being sustained over time. Okay. There's also this patient piece. So the patients will be recruited into the study up until the last 6 months of the study, and basically what we're trying to understand is what is their journey. So the patients are patients who all have issues around weight and who've all declared that they're interested in doing something about weight by virtue of accessing PCM programming. And what are the patients saying about their experience and things that they love or things that they think might be things that they would like to see done differently, that kind of piece. That's where we're going to be getting at that. This is, you may be familiar with this. This is the theoretical domain framework for behavioral change, and this is one of the main theoretical models underpinning the project. This is what I was getting at. There's only one little tiny box that's knowledge, right? I mean, I think in all the years I've had one patient who's lost weight because I said that, the big full sugar Coke bottle that they were drinking every day had a bazillion calories in it. They didn't know that. They stopped drinking it, they lost weight. That's happened once. That's not usually why we make change. It's all these other factors that are important. And so activated patients, which are the ones that we're interested in, are the ones that have actually said, I have capability for change. I'm declaring through my actions and through embracing being participant in a PCN programming that I'm actually at the point where I have capacity to make change. And then what we want to see is, we know based on some of the work, the PCN evaluation, pre and post programming, the patients make valuable change over that window. But what happens to them long term? How do they do? Okay. So the purpose for today is going to be to break out. We have 2 groups which are intended to be stable. They will be facilitated by Robin and Dolores today. Anyways, and we're going to just get the ball rolling and sort of talk about how the collaboratives are intended to be formed, kind of get things oriented, go through the binder a bit. And then we're going to be talking about the topics which could form potential modules for future intervention programs, the things that we want to do here. So, there's a list of topics. It's bi-directional knowledge translation, which is to say we're tossing that out there. It's not exclusive. You guys may say, we've had tons of X, we don't need X, but there's this Y that's not even on the list, which is absolutely pivotal. We want you to get us a speaker who can do some stuff with Y. We want some tools, materials, things like that have to do with another topic that we haven't considered. So that's the purpose for today, is to go through them and brainstorm a little bit about them and see what you guys think about them, and go from there. So these are some of the topics that have come up so far. Weight bias, caregiver fatigue, things around behavioral goals, SMART goals, and other things around behavior change, mental health and obesity, body image, emotional eating, eating disorders, motivational interviewing, stories of success, things people have found that have worked well in their practice, just personal sharing of things. how to handle patients' emotional issues. I mean, Chelsea was talking to me about some stuff that she's been doing recently around mental health and weight loss. And so are there things there that are unmet needs for patients that we could be exploring more? Culture and identity as it relates to food and body. So this is the anthropology piece. I've got both Brent and Jody are anthropologists, and there's a whole arm of anthropology that's really interested in that. So we stuck that up there too. Clinical processes and team-based care. How do you negotiate those roles? How do you negotiate those relationships? How is that working? How do you evaluate it? How do you communicate? Those kinds of things, that's interesting. Efficient patient follow-ups around weight management. Are there ways of doing that more effectively? So those are just some of the ideas that we've come up with. By no means exclusive, and it's not also to say that if we just don't come up with it today, if you happen to be thinking about it in the next while and you think of something else that's cool, absolutely open to hearing about that. The whole thing is to say, what are the things that you think are pivotal that people be thinking of? And also picture yourself, if you were in a smaller community, like we're currently with Better up in the Northwest Territories, and we're in Newfoundland and Labrador. And it's been really interesting talking to the practitioners in those communities, because the resources they have, of course, are very different than the resources we have here. So what kinds of modules and things should we be thinking of that would also speak to people who might be in places which are much less resourced than we are? We are videotaping just the talking parts of these. Again, it's foreseen that those will be videos that we use through the Canadian Obesity Network website that potentially practitioners could access in the future. If someone wanted to do this kind of a program, they could look at some of these videos online and maybe replicate some elements of this. They wouldn't have necessarily a whole group of professionals, but they might be able to get some of that content information in another way. So that's enough for me today. We have a few minutes. Last thing. This is a goal sheet that's in your binder. One of the things that we're hoping emerges from the discussions with the learning collaboratives is that within the discussion of talking about what's happening in the different clinics or talking about some of these different topics, something might spring up for you in your own clinic. In your own clinic setting. Maybe there's something that you think could be done differently for patients or around clinical care processes or something like that you want to actually say, you know what, this is actually really important. I want to kind of hammer this out and set a goal. And maybe Robin and Io and Jody, we can help with facilitating some of those things. Maybe you need different materials. Maybe you want your TV in the waiting room to do different kinds of messaging. Who knows? Whatever the idea is that comes up, this is the place for noting down some of those goals, and we're going to be really interested to see what those kinds of things are. And just like what we do for patients, we want them to be things that we can actually do something with. So we're going to meet after the break, and we'll do all the things that we talked about, and we'll report back at the end. We're going to save a little bit of time at the end to report back. Thanks to all of you. I mean, it's going to be a really interesting journey. I'm open to questions. If people have questions about what we're doing, if things spring up at other points in time, we're going to be underfoot for quite a period of time. So, but we want you to all feel like this is something which you can have ownership of and feel like you're part of, because you are. So, and the Canadian Obesity Network stuff is all in bilingual. And not right now while we're in the derivation phase, but I think once we actually have a lot of these things sort of refined and we hear from you guys about the kinds of things, we can certainly make tools in French. Yeah. That's it? No other questions? I was completely clear? Okay, good. So Aria, you're on.